Welcome to the IDEX Continuing Education Series.
Hello, my name is Philippa McLaren, and today I'm going to be talking to you about tips for getting good cytology specimens. This is part of the IDEX Continuing Education Series, and there's a photo of me out in the garden with my ex-guide dog Paddy, who's 14 now. Some of the things I plan to cover in this short talk will be an overview of how to use cytology effectively in practice, tips to avoid, and places when it's ideal as a diagnostic tool. We want to help you be cost-effective in taking good cytology samples, and some of the things we'll touch on looking at your own cytology, and that will also be the subject of a second talk. We also have some little tips here for how to make the pathologist want to do good work for you, to interact with you easily, and give you reports that are absolutely optimized for what you need. So firstly, it's a good idea to start with what can't be sampled. If it's genuinely too deep within the animal, too vascular and too risky, maybe too small that you can't catch the lesion with the needle tip, too bony or hard so you cannot aspirate material, or too wiggly, which of course you in practice have something that you can do to achieve most of the time, and the limit is what you can achieve clinically down to your ingenuity. It's also important to understand what's achievable and sensible for cytology preparations. Some of the common presentations that I have are cases that are frustrating to the clinician because the cytology technique wasn't appropriate for that sample. So on the right, we have great examples of things that exfoliate really well for cytology and give good diagnostic samples, such as samples of the liver, which doesn't even need an aspirate technique. Anything with pus in, we can look for organisms very easily. Samples from the nose, the feces, body fluids, samples from joints and lymph nodes. But some that are a little bit more frustrating or challenging either to take or to interpret include skin masses, particularly mammary masses, because mammary cytology is essentially non-diagnostic in determining whether a mammary tumor is malignant or benign. The value is in confirming that it is actually a mammary tumor and excluding other processes such as mast cell tumors or straight-out mastitis with bacteria. The mammary epithelial neoplasms, the main criteria for differentiation of malignant processes is invasion, and architecture isn't present on the cytology slide. So no matter how bad those cells are, how many features of malignancy they may have, I simply can't tell you if it's benign or malignant. Spindle cells are another frustration. If a spindle cell process looks the same histologically to such a point that it's really difficult on an incisional biopsy to tell a sarcoma from granulation tissue, how much harder is it on spindle cell cytology to make that differentiation? Urine cytology has a special place, but it isn't necessarily for every routine urinalysis. The scientists are really experienced in detecting white cells, basic epithelial cells. They're not going to be able to tell you differentiation of morphology of nuclear features because they look at a wet prep and they don't look at a stained prep. But the only real value for a pathologist to look at that case as a cytospin preparation of the sediment is in differentiating neoplastic disease. We're not going to give you much more value for a straightforward UTI or FLUTD or FUS diagnosis. So save the urine cytology, ideally, for those neoplastic queries. Gingival samples are almost always really firm, and that's the main reason I've put them on this list. They just don't exfoliate well. And so if something feels hard or bony, and if it's somewhere that's difficult to access for reasons of confidence getting near the dog's face, those would be indications to go straight to biopsy. The spleen is particularly challenging on cytology. Some diagnoses I can make easily, infiltrative neoplasia, mast cell disease, but in many cases the splenic tissue is very complex and mixed, and I might get a confusing or mixed picture. It takes an awful lot of atypical lymphocytes for me to call lymphoma on a spleen, which is why if you think that there may be something like that in the spleen, you might want to go to combination of cytology from multiple sites, which does attract a discount and enables me to give a more complex diagnosis with more confidence. Bone marrow I've put up here because I wanted to take the opportunity to tell you about taking sternal bone marrow. And that's a very simple technique using a 21 gauge needle and a 5 ml syringe, suitable for any dog or cat more than 5 kilos, so a substantial patient. And in some cases, with the right patient, that can be even taken in the conscious patient in sternal recumbency. That technique doesn't allow the collection of a core biopsy, which has some information in relation to things like myelofibrosis, abnormal changes in the bone, or a condition of absence of bone, things like of bone marrow, such as aplastic anemia. But it's really valuable for leukemias, for infiltrative diseases, and for assessing proportions of the red cells and the white cells and the megakaryocytes to try and understand cytopenias that are present in the bone marrow and in the blood. And so submission of a bone marrow sample from the sternum or from the regular sites that you all covered at vet school, plus the concurrent blood smear and the EDTA sample can give you a lot of information. Sometimes you don't even want to bother with cytology, and I think this is an important point. We don't want to overuse a technique if it won't actually make a difference to how you treat, or you're still going to need to proceed to histology, like that mammary sample. Why bother? If you don't think you're going to find out anything relevant, obviously, don't do it. But also, having a look at the slide and what you've achieved is important. If you literally can see no material on the slide and you hold it up to the light and there's nothing on it, probably not even worth it. Try again. You should be able to see the droplets of material on the slide before you even stain it. And if you haven't got anything on there, there probably isn't much of value. People often say, sorry about the blood, or I could only get blood-contaminated slides. And I'd say, yeah, don't worry about that. Sometimes blood is our friend. So particularly from lymph nodes or livers, a little bit of blood helps the material to smooth and spread out across the slide. And as long as it's not too thick and gloopy, we can get good, nice, even spread. If you get a lot of blood, if you're getting material beyond the hub of the needle, that's too much. In that case, what you want to do is certainly make a direct smear, but also put the fluid in an EDTA tube and send that too. So that would be relevant for things where you suspect that there is a lot of fluid within the sample. I wouldn't bother if you're thinking you've got a lipoma when you get back blood. You've probably been lucky and hit a capillary. But if you've got a lesion that is fluctuant or something like that, there might be cells in amongst the blood that we can detect. It will often reduce the diagnostic sensitivity, but it's better than nothing. Pathologists will always tell you we want more communication. We want to know more. Where did it come from? Where have you sampled it? What did you go through to get that sample? We also value knowing what's going on clinically for the patient. If you tell me that an animal has a perianal lesion and fail to tell me that it's PUPD and that there's other clinical features of relevance, I'm not necessarily going to be able to give you as much information. I can point you towards different things depending on what you tell me. So some of the things I need you to tell me. It's really useful to tell me a breed, whatever the species. If you tell me it's a crossbreed, I can't make much out of that. But if you tell me that it's a large crossbreed or a terrier cross or something like that, I have more information. If you fail to tell me that it's something relevant, like a boxer cross or a greyhound that might have clinical changes relevant to that breed, that would be more challenging for me. Tell me about the images that you've taken, or even send them to me. Tell me where it relates to anatomic structures, the size and shape, and I can cope with fruit. I can cope with tennis balls, but centimeters is easy. Tell me if it's ulcerated, because that will make a big difference to how I interpret any inflammatory component. Tell me if the patient is traumatizing it and how long it's been there, and tell me how firm or soft it is. Because if you tell me that a mass is squishy and then I get back something unexpected that looks like bone, then I'm going to want to make a different interpretation. Here is our email address. And this is an email address you can send your images, gross images, x-rays, or anything else like that. You can send that to that email address even before you've submitted the case. Just write the patient name in the email title, send us the details and the information, and then write "see pictures sent to email," and then we'll go find them in that inbox. So moving on to the how-to, and I'll admit that as a pathologist, I don't do this as much as I did when I was in practice, and even then, that was a number of years ago. But the needle biopsy technique is often what's required, and people forget that an FNA doesn't always have to have the aspiration part of that. You're looking to sample the bit of material that's in the core of the needle. And so you can attach a syringe, but you might pre-fill it with air and just be using it to hold as you guide into the lesion rather than to actually suck through the needle. This is really suitable for soft masses, and for things like lymph nodes or liver, you don't actually need to suck back at all. You just want to stick the needle in once through the skin, and then within the tissue, pull back, reposition, and then push back in again. So you don't want to drag through the tissues because that breaks all those tiny capillaries and makes it bleed. Repositioning multiple times, and as soon as any material looks like it's coming into the hub of the needle, then stop. Blow that straight onto a slide, spread it out with another slide. By contrast, the FNA is designed to have the suction, and the risk is that if you have too much blood or fluid comes back, you might get those cells diluted by that fluid. If that's the case, as I've said before, stick that fluid in an EDTA tube, because it will not clot that way, and we might be able to get more material and use out of that. But then start again, fresh needle, fresh syringe, and send those slides as well. The ultrasound-guided fine needle biopsy, I'm not here to tell anyone how to do an ultrasound. I only think in pink and blue. But the ultrasound-guided biopsy has one particular criterion for me, and that is that you wipe off as much of the gel as you're able to before you go in through with the needle. And that ultrasound gel looks clear to you, but it is purple to me, and it looks like bacteria. So it's particularly relevant, as you can see from the photograph on the right. In that cell, there's dots that are probably bacteria, and right next to it, there's a bunch of that ultrasound gel. But if you cover the whole slide with that material, I can't make out anything. I couldn't see mast cell granules, for example, because they're exactly the same color. If you need a contact medium after you've prepared the lesion and know where you're going to be sampling, use alcohol, which isn't going to affect the slides. The surface impression smear. It's a really useful technique. And there's a number of things that can help with this. Firstly, you're aiming to remove all the crust. We don't want to look at the neutrophils and the pus and the bits of foreign plant material and saliva that are stuck into the top of it. Blot it off until it comes back almost clean on the paper. And then you can press the slide to the lesion. You can press it multiple times. You're basically just pushing it onto the tissue and then lifting and pushing and lifting, and then wave it in the air to air dry it. There's another point here with these impression smears. This is something you can do in practice really quickly, and that is to make an impression smear from the underneath the surgical side of what you've just taken out of the animal. Obviously, you might want to be sterile because you're going to be stitching that thing up, but you can get your nurses to put that tissue on the slide, air dry it till it's all gone clear and dry, and then stain it. And you could do that within 5 minutes and be thinking about, have you got all that tissue before you've even closed the wound? So you might know already that it's a mast cell tumor because you did your pre-op cytology. You might have planned to go in for margins and go in and find it's actually all edematous, as mast cell tumors often are, and you think you've got it, but you're not sure. Well, why not sample the bottom of that surgical specimen before you stick it in the histopot, keep it well away from the formalin, and then immediately look and see, are the mast cells at that site? Well, I'm going back in. I need another layer. And if you take that other layer out of the depth of that wound, make sure that you put some sutures, no needles, just a suture, on the side that is the relevant one and mark which one it is, whether that's your deep side or your surface side, and then stick that in formalin in a separate pot so that we know what is your true margin, and we can then give you which side of that tissue and what distance of tissue is clear of mast cells, for example. The other thing that's useful for an impression type smear is a roll prep. So if you take a lump of tissue out of something, or you do an incisional biopsy, or you go in for a nasal biopsy or a bone marrow core, you can gently, with a tip of a needle, just roll that across the slide a few times, and then lift it up gently, drop it in the formalin, again, keeping the open formalin pot a long way away from your cytology. And that roll prep will give you the slides, the cells along the side. And it's amazing how often a round cell process, for example, leukemia or a mast cell tumor, can stain and look much better on cytology than it does on that histo prep. It's not going to damage your histology sample as long as you're gentle. Now, swab collections are another one that really causes us challenge. There is absolutely no point in sending us a dry swab with material on it. It will have desiccated because the cotton just pulls all the moisture out, and what you get is dried out fragments of goo. That's not going to help at all. So if you do need to take a swab sample, if you're trying to do both culture and cyto, be aware of the limitations. We can't make that cyto before we've made the micro sample because it would no longer be sterile, but the cytology is going to be pretty rubbish. So instead, if you can, take 2 swabs, one for me and one for the microbiologist. And the one for me, you're going to want to saline moisten that. And then you're going to roll it across a slide or 2. Many slides is fine, but we might look at the number we feel is appropriate to judge the process. You can do that with the tip of the ET tube. You could do that from a swab within a mare's uterus or nasal samples, even going in through the probe when you're trying to identify a foreign body. The preservation is always the challenge. Now, sometimes you get a report from me that says, this is what I see, but it might not be the whole process. And this is how simple it is. If you go through the lesion and you're absolutely convinced you've gone through the lesion, are you absolutely sure you didn't come out the other side or that you didn't get the material on top as you went through? I often see beautiful cytologies where I've got 3 different processes, and that might be the core of basal cells from the skin as it went in, that little plug from the needle, plus the adipose, maybe plus the mast cell tumor, and sometimes we see things we call collision tumors, 2 processes, 2 neoplastic processes on one slide. What I would say is slides aren't cheap, but they're not that expensive. So don't try and put many things on one slide. It's going to get confusion of information. If you say left and right here, well, just put them on different slides and label them. Labeling is critical to me. So these are some of the things that you can do with your FNAs. Crushing them, not such a great idea. We don't really want to crush the tissue because that destroys the cells. The only time you would want to do that is when you've got really bony stuff and you're just trying to crunch it down a little bit so that you get the particles of bone are spread out and the stuff in between hopefully will come out a little bit. You could then take those bony bits off with a needle because they're not going to go through the processing very well. A squash prep, again, depends on how firm that tissue is. Some things will squash well, some things not so much. The blood smear technique is great, and the blood smear technique is made exactly like a blood smear. There are tips on YouTube for how to do that. The airplane takeoff technique, and it's all in the angle. If it's a very liquid and thin liquid fluid, you're going to want to increase the angle so it doesn't go so far along your slide. You can put the droplets on and then pull them out with a needle. Sometimes that works. You probably need to do it quite a lot because if it's a thick blob of stuff, you don't want thick blobs left behind. The roll prep is nice. As you say, just shuffle it along the slide. The splatter prep, well, sometimes the splatter prep is great, but it depends on the viscosity of the material and how fatty it is. If you get visibly undulating blobs of stuff on your slide, that's going to be too thick. So the ideal is to take that splatter and then just gently put one more slide on top, no pressure, just one slide on top, one slide underneath, put them together, either lift off straight away or slide along without any pressure, and then you've got 2 good slides. Yeah, let's be ballerinas about this. On the left-hand side, you can see this is our splatter technique. This is our smear technique with the material pulled right the way along. And all of this material here, I can guarantee that that will be so spread out that it's just nuclear debris. The bit in the middle, I will be looking around these edges here. You can just about see the little patches around the edges of the thick bit are where I'm going to end up. And here I can see a few droplets on there. A little bit of blood goes beyond the staining area at the end of the slide. So the last 8 millimeters or so is not going to get stained in our techniques. Nextly, I have some tips for you on how to manage fluid samples. Fluids can cause quite a lot of challenges, and you have a number of options for managing them in the clinic. Often, when you're taking a fluid sample from a body cavity, it's quite an urgent diagnosis. So it's important to be able to pull out the main critical features, things like pus, things like hemabdomen. You can pick out a lot of information from your simple sniff test, your PCV, and your biochemistry testing, if it's appropriate type of fluid to do that on. CSF, urine, body fluids, washes, any of those, whether you've added saline or not, they will preserve best for cytology in EDTA. That's basically a blood tube. We're not worried about the volume. We don't need a mill to be able to fill an EDTA tube. You can just pop a bit in that fluid tube and then label it with the site, and then we can do all the cytology techniques and the cells will preserve well. What we can't do is grow anything from it. It will stop bacterial growth, which is one of its beauties, why we like it for things like BALs. But it's ideal for PCR because it preserves that nuclear material, and ideal for cytology. So you might need to send both tubes. If you're doing a CSF, usually the best advice is to make sure that you miss the first drop if it's bloody. Otherwise, get it right there with your plain tube first, and then your EDTA tube. You might get 2 drops in each, and we can still work with that. So a little bit of bonus information, and this is said with a great degree of caution. The use of in-house machines for analyzing the chemistry components and the cell counts of fluids. It's something we hesitate to advise about, but we do it ourselves in the lab. We do it with caution because we don't want to stuff up our machines. Our machines are essentially the Big Daddy versions of the in-house diagnostic machines, and they work on the same principles. So we put nothing near those that is clotted or viscous or in any way sticky. We want to make sure that we're not going to block the machine up and cause major problems. We are able to do things like basic cell counts, and you can also do a basic cell count with a technique through comparison of cellularity compared to a blood smear, for example, or doing a manual chamber count if you're feeling really enthusiastic. But your ProCyte or your laser site is equipped to do cell counts within a certain range, the range that would exist in normal cellular blood fluids up to about a leukemic range. So anything from 1 or 2 up to 100 or 2 is fine. Some of the paucicellular fluids, those unusual cysts in the skin or CSF, they're not going to register. Biochemistry I find really useful, and we reported on all of our fluids that we measure a range of analytes. We're basically comparing to serum and what we know of the principles behind how the biochemistry components will diffuse across tissues and into different compartments. So amylase and lipase are useful for if you think you might have a pancreatitis. I don't run them on every sample. That would be excessive. But if the history says suspect pancreatitis, I can tell you if the pancreas is seeping enzymes into the peritoneal cavity. Urea and creatinine we can measure for a short time to detect, is it a ruptured bladder, is it renal failure? And the critical thing is how long has it been going on and how different is it from the serum. So these are measured in parallel with the serum chemistry. Cholesterol and triglyceride will tell you how that sample relates to the lymphatic drainage. Is it chylous or non-chylous? And the proteins will give you those classics of exudate versus transudate or modified transudate, or as is now known, protein-rich transudate. What we do in the lab with our slides, we do our chemistry measurements and our cell counts if it's appropriate, and then we make fluid preparations. And the machine on the left is a centrifuge that is optimized for cytology samples. It's a very slow speed, very gentle, and we create the samples with a little bit of fluid into a specialized chamber. And that gives us a circle like this of the cells that are concentrated, and the liquid component goes into blotting paper around the outside, and a direct smear to go with it. And this is our automated stainer. It is a Ginza stainer, which is why it's so good at picking up mast cells compared to DiffQuick. And that's a high volume throughput system. It takes about 10 minutes for slide to get all the way through that stainer. So, it's not an immediate turnaround. It's not as fast as DiffQuick, but the quality is much more reliable. One thing that I would emphasize at this point, it really is worth buying the frosted edge slides because you need to label them. You need to label them with pencil, at least a patient name, preferably a site on that frosted edge. If you don't do that in a human medical system, they would reject the case outright. So we cannot report anything that is received unlabeled. I don't care if you're labeled the mailer. What if? If it was a human, you would never consider reporting something that was inadequately labeled. So put your label on the slide itself, pay the extra, or just use the slides that we provide you, and make sure that you order enough in, and put the dry slide unstained if you don't want to. Quite happy to receive DiffQuick as well. If you can, take multiple and stain some to check you've got something useful, and maybe you can make a diagnosis yourself. but send us the whole lot, including what you saw, so that we can tell you what we interpret of what you saw, and you can learn at the same time, and so that we make sure that we're looking at the same stuff. Because if you're looking at one slide and I'm looking at another, you might see something very different to what I see, which is why we end up looking at multiple slides for the same case. That's a little picture of the little device that enables us to put the fluid. We put the fluid in here, and it's pushed by the centrifuge onto that little dot of the slide. We end up with a variety of preparations, some thick, some thin, and we put a little circle around where we put the material. So this is ways that you can do this in practice. Now, sometimes we understand that it's a weekend, you need an urgent diagnosis, you're trying to manage a critical patient, you haven't got time to wait. And so you might have a fluid sample from the pleural cavity, for example, and you want to look at it, but it's not got a very high number of cells, which is probably good news. You want to concentrate those cells in a way that you can look at them without spending hours scanning that whole slide trying to find one or two cells here and there and make a judgment call. So you can treat it rather like urine. Low-speed centrifugation, remove the supernatant, resuspend the pellet with a little mix, and then make a direct smear from that. If you do that before you send it to us, please tell us that's what you've done, because we might make the wrong interpretation if it's been concentrated and we didn't know. The same would apply to urine. You can make a barrel chamber by cutting off a syringe or making something circular, putting that on the slide, maybe with a little bit of Vaseline around the outside to make a seal. Let the material settle in that until all the material goes to the bottom, remove the liquid, and then scrape off or scalpel off the Vaseline, and then stain that material. But the very, very simplest one is to make a line prep. It's just like a blood smear. Instead, rather than going along the slide and taking off at the end, you're going to go along, and then you're going to stop. You're going to lift the slide so it's from the horizontal or nearly horizontal to the vertical, and then you're going to lift it off the glass slide that you're spreading the material on. So that's touch the material at the droplet, move it along, keeping the slide attached, then stop and remove the slide. You're lifting that spreader, and then you've created both a thin area where the fluid is spread out and a thick line where all the big cells have been spread and distributed to the end. And you know that that area at the end is where all the cells will be concentrated, and you can see that when you stone it. Here's a hot tip. Basically, if you think about a body fluid, the critical number is whether it's a modified transudate to transudate or an exudate. And an exudate cutoff in most situations is about 5. Now, your white cell count in your average patient is somewhere between 5 and 12, let's say. If it's a greyhound, maybe a little bit lower. But you can get a collection in your clinic of basic normal dog and cat blood smears or horse blood smears, and you can keep those on your shelf, or stained up, maybe cover slipped with a bit of, or just painted over with a bit of clear nail varnish. And you've got that nice example of this is what a cell count of X, Y, and Z looks like. This is what normal leukocytes in this species look like. When you look at a direct smear of the fluid, if there are more cells on that spread slide made the same way as a blood smear, it's an exudate because it's got more than 5 times 10 to the 9 white cells per liter. It's got more cells than your blood smear. And that's a kind of tip to understand, just the very basics. It doesn't look like pus. An exudate is not wall-to-wall leukocytes. It can be much more subtle than that. We're going to stop there today, and the next part of the talk will be about how I approach the cytology slide when I'm trying to make my diagnosis. Thanks for joining us, and come and join us for the next talk.